Okay. Good evening, everyone. Welcome to the Health Overview and Scrutiny Committee meeting today. Before I start, I would just like to read the fire evacuation notice. In the event of the emergency alarm sounding, please leave the building using the nearest available emergency exit, as directed from outside this chamber, and assemble at the car park across the road from Bedford College main entrance, which is to your left as you leave the front of Borough Hall. Please remain there until you receive further instructions. Thank you. So, agenda item 1, are there any questions from members of the public or members of the council this evening? Councillor Lee Coombs.
Thank you, Chair. I just wanted to confirm, if I may, my colleague here from Health Watch, Bedford, they can participate in conversation, ask questions, and just not vote.
No,
can I just confirm that was correct?
Yeah, that's correct.
Thank you.
Okay, any other? No. Okay, so thank you. Move on to agenda item number 2, apologies for absence. Are there any apologies for absence this evening?
I'm subbing for Councillor Harish Thapar.
Thank you. Move on to agenda item number 3, minutes and actions of the previous meeting. Does the committee approve the minutes of the meeting held on the 1st of June 2026 as a correct record and authorise me to sign them? Those in favour, please show. Thank you. Thank you. Does the committee note the actions on its action tracker? All those in favour, please show. Thank you. Move on to agenda item number 4, disclosure of local and or disclosable pecuniary interests. As I know, members appreciate it is important that we observe the provisions in the Code of Conduct relating to the disclosure of interests. Can I ask members to disclose these interests and the existence and nature of any local and or disclosable pecuniary interest in tonight's business? Thank you. Move on to agenda item number 5, introduction to the Central East Integrated Care Board Strategy, Our Way. Please could I ask Georgie Brown, Deputy Director, Neighbourhood Health, BLMK, Central East ICB, to introduce the item.
Good evening, everybody. Pleased to be able to come and speak to you today about Our Way. I know you've got the paper in your packs, so I'll just go through a couple of sort of headlines. Looking at the microphone, sorry. A couple of headlines that I think may be of interest. So on the 1st of April, Central East ICB published its new strategy, which is called Our Way, and this includes the priorities, programmes and the measures of success that we will be planning for over the next 5 years, mainly guided by one question, and that is what best serves our population. So Our Way sets out our 5-year approach to commissioning, and that's built on the principle of quality being the strategy, improving quality, access, experience, outcomes and effectiveness for our residents and patients across Central East. We will be focusing on what matters most to people and the systems, and focusing primarily, initially, on improving access, making the NHS financially sustainable and more productive, and supporting people to stay in work and remain economically active as far as possible. How we will be doing that, I think, is important, and that will be through a process of improvement, codifying and scale. We will be looking to test changes at a small scale to prove the impact, and if it's proven to work, we will then be looking to codify it to a standard evidence-based model and commission that once across the system. So instead of repeating and duplicating, we will learn from what works well and roll that out as far as possible where it's appropriate. Excuse me. So the delivery, the same process will be followed in terms of being shaped by a single care model across 5 stages. So everything we will look at will be looking at prevention and screening, supported self-care to residents and patients, proactive risk identification and outreach, care coordination for those with complex needs, and crisis response linked to recovery of individuals. What that looks like initially is we will be looking to focus prevention screening for cancer, self-care for MSK, utilisation risk management in cardiology, care coordination for advanced illness, and acute care pathway for mental health illness. We've got a number of priority starter programmes which have been chosen and as they address the major population needs we have across Central East and offer opportunities to reduce utilisation and have evidence-proven elements. We'll be looking at dermatology, diabetes, neurodiversity and neighbourhood health teams. So neighbourhood health teams are the operational level prevention, the proactive care, coordination, crisis response integrated around people and places. I think we have 16 across Bedfordshire, Luton and Milton Keynes, and for the borough we have 4. And that will be neighbourhood health teams with mental health, community, primary care, acute services linked in and linked into integrated neighbourhood health teams with wider social care, local authority, VCSE and local community groups tied in to support the residents within that neighbourhood. We will be looking and focusing on top 3 system outcomes, and those outcomes should show whether the system has shifted towards better access and sustainability. So we'll be looking to increase patient reported satisfaction across primary care. We aim to decrease the average number of days residents spend on waiting lists across a range of our services, and we would like to flatline the average NHS spend per resident. That's not reducing spend, it's spending better. I think it's an important takeaway from that for me. We'll be looking at early intervention measures, earlier diagnosis, as we know that's so important to patient outcomes and experience. I know you have a paper in front of you. I don't want to read it all out, so if there's any questions or discussion you'd like to have, I'm really happy to walk through that. Thank you.
Thank you. Are there any questions?
Oh,
one at a time works. Chair, I just realised I need to declare an interest. As the new ICB includes Cambridge, I've done occasional work for Cambridge University NHS Trust, so I just need to declare that. Thank you.
Thank you. Councillor Booth. Oh, sorry. Councillor Booth.
Thank you. Thank you, Chair. I got a couple of questions, but I'll go first one. What formal mechanism will exist for Bedford Borough Council and local residents to influence decision-making within the new Central ICB, Central East ICB?
Great question. So within the new Integrated Care Board governance, there is a subcommittee of the board, so I'll start at that level. There's a Neighbourhood Health Committee, which covers BLMK. There's also one for Cambridge and Peterborough and one for Hertfordshire. So that will be sort of the neighbourhood focus, delivery focus for BLMK feeding into the wider ICB structure. A core component, which I haven't gone through today in terms of how we will do that, and that process of quality improvement we're taking. At the heart of that is the resident, patient, carer, family voice. And we really, and frontline staff, we really want to engage with those groups to help us design, understand what matters most, and to take their experiences into account.
Another question, if you allow me, or
Can I go over to Councillor Booth and I'll come back to you, Councillor Booth.
Thank you, Chair. Having been involved previously with the CCG before it became an ICB, my concern is, under point 7 on your report, how we will work, improve, codify and scale. Because I'm aware that there's an awful lot of bureaucracy, form filling, and attempts to get funding for various projects to improve things. I was around when fit testing and D-dimer testing was trying to become part of just general everyday use as part of the hospital. And I'm aware of how many years that took to actually gain legs, get started to work, even though it was saving a massive amount of money. The amount of evidence that needed to be provided to warrant the use of this new D-dimer test was huge. So I'm slightly concerned that it's all well and good looking at how to improve things and then scale them up, but if the bureaucracy and the levels of difficulty of getting those things done hasn't been looked at, that these things might fall foul and just take many, many years to improve things. So has that been looked at? Has the bureaucracy, has the process been looked at as well, so that if things do work at small scale, they can easily be scaled up?
Yeah, so I think there's several elements to that question. So obviously there are formal processes, procurement rules, consultation that we have to abide by. We're trying to focus on a few smaller things so we can wrap that resource around it and not try and do 100 things all at once. So whilst we are working on the clear evidence base, best practice of what those pathways or services look like, learning from what's already in place, not only within Central East but wider, there may be decisions that we need to stop doing things. There is also what can we do within our existing contract and commissioning arrangements to realign or refocus our services and how people work together and how our teams and organisations work together, as opposed to the answer as a contract or a new commissioned service. Is how do we reframe and reorganise what we've got, and we do that by bringing all those people and the residents in a room to work out how we can do something different with what we've already got. But yes, the points you raise are absolutely clear, that we are trying to work through that, and I understand, although I haven't seen it, I do understand that we are looking at some transformation funding to front-end some of these services. Obviously, in the prevention and self-care, we need to front-end that before we can see the benefit of that in our wider services.
Councillor T.
Good, Chair. My question is access to the care. Improving access is identified as a top priority. So how will the success be made locally, Bedford Borough, rather than across the whole Central East area?
Sorry, which was the priority area you mentioned, sorry? Improving access. So although that is a Central East ambition, that is driven by local information from across the Central East patch, and at an aggregate level, that is a key issue that we see in our data. It's a key issue that we see in our experience and inquiries team from what residents and their families are feeding into us about what we know is the big challenge for people. So that along with, so everything that we're doing is on a very focused evidence base. What is the data telling us around where we have challenge and where we have opportunity to realign, make simpler, easier to access for people. And often we've looked at individual patient journeys, and from accessing through a GP, potentially then into a number of range of different services, and then back to somebody else, and then back to, and that bouncing around and ping pong. We've designed that, not intentionally, with the very best, with the best intentions, but that's not the best thing for residents. It's not the best thing for the service. So how can we make that simpler with all those professionals understanding, working, and communicating together? So what we will do, so obviously there will be an ambition that we improve access across Central East, and that aggregate measure will be culminated from what we're seeing at the local level at Bedford Borough, Central Bedfordshire, Milton Keynes and Luton from my perspective, and then even down to local PCN practice information, so we'll be able to target where we've got particular issues.
Councillor Lee, please.
Thank you. I was looking at the part in your strategy that said rooted in clear and reliable data. Will you be able to provide data for Bedford Borough to this committee?
Yes. Absolutely. And that's something we're absolutely championing, that we need it not only for Central East, we need it for BLMK, we need it for Bedford Borough, we need it for our neighbourhoods. Absolutely, and we're working closely with public health teams and the population health teams to bring all that data intelligence together, so it's one version of the truth, if you like. We're so rich in data, it's how do we turn that into something meaningful to direct where we're going. But yes, we will. I'm really happy to bring that back to this committee.
Councillor Abood.
Thank you, Chair. This goes a little bit beyond the report that we have in front of us, but as a HOSC, we've not been aware up to now. Obviously, the new ICB is relatively new. When we heard that it was being formed, we had our questions then about how things were going to work, and we're still not necessarily any the wiser about how things are going to work as far as the structure of the new ICB is concerned. The question that we've been asking all along, well, I've been asking all along, I don't want to drag everyone else into it if they haven't been thinking this, but is where does the money stop? Because the money's going to come down from central government to Central East ICB. And does it stay there? Does it filter down to neighbourhoods? So are we looking at BLMK, that they have then the funding, so that filters down? Or is it going to be spread across the entire area, so different areas might receive different amounts? And also the priorities for that all the different ICBs had. So for example, for ICB and estates within BLMK, we did originally have 53 priorities for estates. When the government reduced the funding, that went down to 23. Are those 23 priority bits within the BLMK area now going to be shuffled up with the priorities for everybody else, for Central East to then provide a new priority list? So is there a danger that some of the priorities that BLMK had are pushed further down the list because we're now part of this much larger ICB? I appreciate you may not be able to answer that, but as I say, where the money is coming from and how much this being part of this new ICB is going to change things locally hasn't actually been made particularly clear to us as a HOSC. So we're still trying to grab information wherever we can. And that's one of the reasons for sort of inviting the ICB here, really, was to try and dig into a little bit deeper about how things change for us locally.
It's a really good question, part of which is still being worked through. So, and I think there's the funding for the ICB is based on population size, of which BLMK has a population, of which Bedford Borough does. So there is resource within Central East that is absolutely for BLMK. That's not to say that should some of these priorities that we're looking at, that we're looking maybe to commission once across Central East, there will be resource from each of those legacy ICB areas that would feed into that. There is a process and coming through sort of the neighbourhood health strategy and that direction of travel. There's discussion of delegated commissioning, delegated budgets, new contracts for, post-holiday brain, multi-organisation, I can't remember what the names are. Let me come back to you on the names. But there's different structure mechanisms that for delegated commissioning, delegated funding. So we may commission a organisation, a provider, a group of providers to deliver our neighbourhood health, the health element offer, as an example, for our populations. So the money therefore should be working across all those different tiers. All of that is still being framed out, both nationally and locally. The priorities for Bedford Borough should remain. The priorities for BLMK and the needs of the population should remain. That hasn't changed. How we solve that and respond to that challenge is what may change. So it may be across Central East, it may be across BLMK, it may be across Bedford Borough and or just in that neighbourhood. So we are looking at what we have currently commissioned across the patch, using all of that resource. So the Better Care Fund, as an example, we're going through all our health contribution, and are we getting what we need from that? Is there a way of doing it better? We do still have an estates team. Those challenges that remain in Bedford Borough still remain, so we should continue to work through those.
Thank you. Councillor Lee Coombs.
Thank you. So with that 50% revenue cut that you're trying to achieve, can I ask you specifically what is going to change for Bedford Borough residents in the next 12 months?
So the 50% reduction was in the ICB headcount. So that has happened, and we're working through the final stages of that in terms of getting people into post. That was that 50% reduction to operate on £19 something ahead of our population. So So what I'm quite excited about in my role is the reframing of that organisation to focus on what only we can do as the ICB. So that strategic commissioning, but the development of the Neighbourhood Health Directorate that I'm in and the team that focuses on BLMK. It's a real opportunity for us to focus just on BLMK issues, just on Bedford Borough, our four Bedford Borough, Central Beds, Luton and Milton Keynes. We have members of the team aligned to those areas from both a neighbourhood wider working perspective, but also from a primary care perspective. So I think there's a real opportunity for that team to wrap around and work alongside our local partners, our local authority partners, and even at a neighbourhood level to get even closer to residents and patients, and to advocate for that into the new Central East patch and vice versa. So in terms of difference, I'll answer your question. Come back to that, sorry. So it's going back to that access is a major issue. So how are we reducing those waiting lists? How do we bring care closer to people and identify? So instead of waiting for people to deteriorate or for conditions to worsen, we actually wrap around that care in a proactive way. So we're identifying people. Our focus this year is frailty. So really working with those individuals and identifying those that are at risk of frailty, and then coming up with sort of care plans wrap around those individuals to prevent that deterioration, prevent people where we can ending up in hospital, and should they end up in hospital, we get them back home or to their preferred place of residence as soon as possible. So we should see simpler access, better access, and care that's wrapped around those individuals, and responding to those kind of crisis deterioration events in a more rapid, planned way.
Thank you. Councillor Graham Coombs.
Thank you, Chair, and thank you for the introduction to this. My question is specifically on the sort of the strategy itself. Many of us have sat here and seen before the ICB the CCG, and before the CCG the PCT. Before the PCT, I can't remember what came before that, but there was another one. And we see lots of different strategies. Then sometimes a change of government comes along and we all walk in the other direction, and then the government changes again, we go back in the first direction. We've sat here and seen a lot of words and a lot of strategies over the years. What's going to make this different? What is going to make this work where, you know, despite all of the best intentions we've seen previously, the NHS is where the NHS is? And I don't think any of us would say it's all, you know, it's all perfect. And the second part of my question relates to the systems outcomes that you've got listed in this report, which are, they're either very ambitious or they're hostages to fortune, depending on your perspective. Increasing patient-reported satisfaction with access to primary care. Well, we've all discussed here many times about access to GPs. That is a challenge in Bedford Borough. Decrease the average number of days residents spend on waiting lists. Good luck with that. And flatline average NHS spend per resident, which I'm curious, is that, are you going to adjust that for inflation, or are you looking at year-on-year cuts? If you're going to flatline it, and inflation isn't taken into account, you'll actually be reducing average spend per head over the years. So they're all major challenges. I mean, credit for taking on stuff that's big and bold, but I just wonder, is it not too big and bold?
I think it has to be ambitious. And I don't think anyone in the ICB would shy away from that. And this is all conversations we've had internally. These are all things we've grappled with for a number of years. But we're all residents and patients ourselves. We're all, and these are the things that matter to us as individuals, us as our family members, and we know it's what matters most to our residents. So that's where we need to go for it. I think, how is it going to? So all those changes you've discussed, I've been part of the PCT and in various forms and through all those iterations, and this feels different. So how the organisation is committed to working. So it's not only what are we trying to do, how we work as an organisation has really changed. So gone are the days of thinking around the answer to a problem is we'll have a programme board that meets monthly. This is, let's focus on this one thing, let's meet 2-3 times a week, go through it, come up with an idea, try it, test it, adapt it, keep going and go for it. So that whole organisation is framed around doing things differently, which feels really exciting. And the investment of the organisation into our evidence, our data, our BI, technology to really inform where we're going and to really look at the measures that are important. It feels different. Okay.
That's fine. In which case, how soon can you come back to this committee and show us where the difference is that you've made?
I like a challenge. So I will refer to my colleague in front of me. For the first challenge, I think let's bring the data to you. Let's show you what's happening in Bedford Borough and where those significant issues are, and what that looks like. So we've got a baseline and a starting point, and then we can look at coming back and saying, okay, so in a period of time, this is the difference that's been made. We know we have increased primary care access over the last year. The frailty neighbourhood health teams have got to be in place and ready to be commissioned by April 27. So this is happening kind of as we speak. We've got a fantastic pilot going on with Bedford Borough at the moment, Bedford Hospital, with borough colleagues around our discharge processes and Home First, which the early 3 weeks of it has shown incredible improvements and benefit to residents. I think we've reduced length of stay by 5 days. So we've gone from average of people wait from when they're ready to be discharged to when they are discharged of around 6 days. I think we're down to now about a day. So people are having those assessments and things in their own home, and more people are going home as opposed into sort of bedded care or residential nursing care. That's the first 3 weeks. It's really early, but there's some really exciting things starting to happen by trying something different.
Thank you. Before I go into Councillor Atik, I've got a question as well, if that's okay. Yeah? So my question is, how will the progress against the Our Way strategy be reported to the ICB board, local authorities, scrutiny committees and the public, and will a regular performance dashboard be published?
Yes, dashboards are being produced and published. The Our Way strategy is where the entire organisation is focused, and the ICB board will be overseeing that delivery, our focus, our delivery against our ambition, and the approach we are taking. Similarly, that will also go to the Neighbourhood Committee for BLNK and the others, and that will then focus more on BLNK local information, of which local partners, local authority are all members on that group. Linked to the Neighbourhood Committee, we've got the place boards across each of our local authority areas where we'll look at specific place-based information.
Councillor Atik.
Thank you, Chair. My question regarding prevention, I know my local councillor already touched on the prevention. Prevention is a major theme. What investment is being made to prevent ill health rather than simply treating illness? And how will ICB work with Bedford Borough Council on the issues such as housing, obesity, smoking, physical activity, and mental well-being?
So I'm not personally not that close to the prevention agenda at this moment in time. I know we're working really closely with Vicky through the executive leadership group that Bedford Borough has. So if you don't mind, I'll take that question away and come back to you with a proper response from the teams that are leading on the prevention areas.
That's fine.
Okay.
Are there any more questions? Are there any comments?
I just want to say thank you for coming in and for bringing the strategy. I think it would be helpful if we could see updates from time to time on how things are going with performance dashboards and things. But yeah, best of luck with the strategy.
Thank you. Really happy to work on the frequency that would be helpful for you, but thank you for the opportunity.
Thank you. Does the committee wish to receive any further information regarding the Central East Integrated Care Board strategy? Yeah. Okay,
I think it would just be good to know how they're going against it, you know, whether they're achieving it.
Yeah, I'd just like to say thank you for sharing your report, and we look forward to hearing more about how local communities, councillors and scrutiny members will get involved as these proposals are developed and implemented across Bedford. Thank you.
To ask, obviously, you'll share the strategy papers. Will it have tactical plan there, or just the high-level strategies? Obviously, you're talking about the pilot plan, etc.
The Our Way strategy is kind of the guide that's leading us through the next 5 years and how we will approach under all of that. So under each of those priority programmes, the pathways, the measures, there are delivery plans for that. So neighbourhood health teams, as an example, we have an entire work programme with milestones and everything that we've got to achieve. I'm happy to share any of that may be of interest, but there's a lot. Yep.
Thank you. We now move on to agenda item number 6, Bedfordshire Hospitals NHS Foundation Trust Draft Quality Account 2025-26. Please could I ask Karen Sobey-Hudson, Deputy Director of Quality and Safety Governance, and Paul Teesey, Medical Director of Bedford Hospitals NHS Foundation Trust, to introduce the draft quality account for 2025-26.
Thank you, Chair. Thank you for inviting us here to present this evening. It is the actual final version, but we can add in your statement afterwards as a sort of updated version. At the time, we thought we might send a draft, but this is the final version. So I just wanted to introduce it, and Paul Teesey will chip in with anything that he can help with on questions you may have. So the quality account provides a clear, comprehensive and balanced overview of the quality of services delivered by the Trust during the reporting year 25-26. It reflects the Trust's commitment to continuous improvement, quality and safety governance arrangements and use of quality and safety data, and improvement against best practice standards through clinical audit and learning activities. The Trust made positive progress against the Trust quality priorities during 25-26, and you will note this year ongoing focus on our improvement approach, strengthening patient safety in specific areas, including VTE risk assessment, antimicrobial administration as time critical for patients of 16 plus with a high risk of sepsis who are screened, and where screening is positive, making progress to undertake administration in 1 hour. Separately, antimicrobial resistance is a known patient safety risk. We are committed to improving the timeliness of the IV to oral switch and to reducing unnecessary exposure to antibiotics. We're committed to improvements in how we enable our staff to communicate with patients and families, working to improve access to interpreting and translation services using our on-demand audiovisual communication system. We know this will support clinical care in many areas, including maternity. On page 61 and 63, under Learning from Complaints, we describe some of the ways we are working to improve how we communicate with patients so they receive a positive experience, listening to what they have told us when it doesn't work for them. We are going to focus in our quality priorities on how data can inform our understanding of health inequalities in patient safety, building on the safety surveillance work of the past year. We will be reviewing our incident reporting data fields relating to local population demographics and known inequalities, bringing analysis to incidents and applying this to complaints. This will then inform improvement activity. Violence and aggression reduction is essential to morale for staff and psychological safety of patients who witness violence and aggression in ED and on our wards. This work is led by the Violence and Aggression Group, working closely with our seconded registered mental health nurse. You will see on page 25 and 26, significant work is underway on our digital strategy, including Badgernet, which is the electronic patient record for maternity and neonates, and this will enable us to share information across other maternity services. In terms of best practice standards, we participated in 61 national audits and 6 national confidential inquiries. You will find in the appendix a sample of clinical audits and improvement projects. Appendix 1, page 109, it highlights nearly 500 and 16 of these local internal audits and improvement actions were for Bedford Hospital, which illustrates our commitment to improving standards of care. Clinical research is important to improve the care we provide and the clinical options and opportunities for some patients whilst contributing to health for the local populations. We undertook awareness campaigns in Bedford and Luton, and we recruited nearly 2,000 patients to these studies. We continue to develop our data quality and use a range of Power BI reports to create dashboards providing detailed and timely information for staff. The Trust Overall Data Maturity Index score is above the clinical average at 95.7% against 87.9%. Other aspects, referring to the National Hip Fracture Database, Bedford Hospital is no longer a mortality outlier for hip fractures. You will see that our site redevelopment continues, which supports high quality care through the same-day emergency care unit at Bedford Hospital and the final phase of the Community Diagnostic Centre for Therapies and some phlebotomy services at Gilbert Hitchcock House. The new diagnostic capacity phase was launched in October, with the centre now fully operational, increasing testing capacity by up to 50% for many imaging modalities, with planned diagnostic care more conveniently located for many patients. Further refurbishment works were completed in June. The Trust maintains a good rating with CQC overall, although we do acknowledge the inadequate rating for maternity services. There is a very big perinatal improvement programme and intensive work underway to improve this service. We had a Trust-wide well-led inspection from the CQC in March, and we await the report. Thank you.
Thank you. Are there any questions on the report? Councillor Atik.
Thank you, Chair. My question is related to maternity services remain rated inadequate by CQC. What measurable milestones are expected during 2026-27 to demonstrate the improvement?
So, good evening. So, there's been an enormous amount of work we've undertaken in maternity. So, since that first CQC inspection, we have a whole perinatal improvement programme, which is led by Liz Lees, our chief nurse, as well as a perinatal assurance group, which provides much more assurance to our trust board. It is an enormous programme. As I say, we've appointed new clinical leads. We have a new director of midwifery, new clinical director, and a very strong leadership team. We've made enormous progress in all of the areas that we need to address. We are actually looking forward to the CQC coming to do a re-inspection, and we strongly believe that we'll improve our rating. You'll be aware of some national reports that have been in the press. So the Ockenden report, which was in relation to maternity care in Nottingham, and the Amos report published last week, which is around 12 maternity units, which is including us. Myself, Cathy Jones, the acting CEO, and Liz, Director of Nursing, attended a national event in London last week. There's a real drive for a 100-day, 10-point plan to improve maternity. It's a national issue, but we have made enormous progress in those metrics. Our board have improved quite a large workforce investment, and we're clearly in a very challenged financial environment at the moment, but we've invested £6 million in additional workforce over the next 2 years, and that's both in midwifery and in medical workforce to address some of those issues. I think a theme that has come through is some incivility, and so we've introduced our anti-racism and incivility charter. We've had a number of professional behaviours workshops, led by the GMC and the NMC. So again, we have taken that really seriously. So I think that's some of the milestones that we've made.
Thank you. Councillor Coons.
Thank you. So the quality account puts patient safety and staff morale front and centre. I just wondered how you're going about, because I've heard about lots of agency staff to cover theatre shifts. I just wondered what's happening there and how that is affecting staff morale for your full-time staff and what it's doing to patients.
I mean, I can answer that. It's unrelated to the quality account completely, but if you want me to cover this additional subject, I can do. This is very much a consultation that put in place around appropriate overtime payments. There is a national framework for overtime and additional bank work. The Trust was an outlier, and so we've actually moved and consulted in consultation with the unions and with ACAS, and appropriate timescales for consultation, but you'll be aware from the press that there is industrial action underway, and there will be effects on patients with cases being cancelled. We remain in regular dialogue with Unison. We've had multiple meetings, Monday, Friday, Monday again today, so to try and resolve this. But it's a national issue. I think it's really important that if we make an inappropriate arrangement, that will have a knock-on effect across our trust, local trust, and across the country. There is it is a very strict agenda for change pay framework. It's important to note that the arrangements were put in place many years ago when theatres were relatively understaffed. We are fully staffed for a normal working week. Now, staff will often choose to undertake additional work at weekends, and the dispute is around the overtime versus bank rates. So on a Saturday, as an example, an overtime rate will be 1.5 times your basic. Under the agenda for change, which is what we need to abide by, that's 1.3 times. On a Sunday, overtime rate's 1.5. The agenda for change bank rate is 1.6 times your pay rate. So on a Sunday, staff would be slightly better off. Saturday, slightly worse off. But it's a difficult dispute. We're actively managing that.
Thank you. Any more questions? Councillor Bridge.
Thank you, Chair. You mentioned in the report about exception reports used by doctors to inform when their day-to-day work varies significantly and or regularly from the agreed work schedule. I know this is for doctors. Is there anything for any other medical professionals to report their alterations to their hours?
This is very much something that was introduced in the 2016 junior doctor's contract, now resident doctor's contract. There's a slight change in the process for doing that, but we've had this for 10 years and it applies to doctors only.
Is there any other mechanism? I'm thinking about for nursing staff, for example, who miss their breaks because maybe they're short-staffed. Is there any way of them reporting back that they've been missing their breaks, etc.?
Again, obviously that would be for Liz, our chief nurse, to answer, but actually they would be working with their matrons in their departments, but there's not a formal reporting mechanism as there is with resident doctors.
Thank you. Do you have another question? Or? Yeah. I'll go next and then Councillor T, if that's okay. So my question is, given the size of the Central East ICB footprint, can you confirm that all key performance measures, including waiting times, patient satisfaction and inequalities, will be routinely reported for Bedford Borough, specifically rather than only at aggregate ICB level?
Perhaps I'll start off and I might bring Karen in. Certainly for our trust reporting, we will not be reporting at borough level. We will be reporting for our trust level and at site level, because we had 2 hospital sites and 3 local authorities. So we would not report that data at borough level. Now, if there's a particular need to drill down to a certain aspect, then of course we can do that, but it wouldn't be part of regular reporting.
Sorry, am I able to press my button? That would be the ICB will be able to do that for the work. So we have an understanding of all the access points that Bedford Borough residents use. I think we've got, last count, it's around 9 different hospitals Bedford Borough patients can access. So we would be reporting for the whole of the Bedford Borough population. Paul will just be focusing on the trust.
Yeah.
Between us, we've got it.
Yeah. Councillor T.
Thank you, Chair. My question is regarding virtual wards. So how will the expansion of virtual ward will be evaluated to ensure patients receive safe and effective care at home?
I haven't included anything about virtual ward in the quality account, so I don't have that information to hand.
And also virtual wards is a really important part. We've done a lot of that with our frailty team, and that's really important. So we have a group of frailty advanced care practitioners. They're really making great progress in virtual wards. We have respiratory virtual wards. So it is absolutely something that we do. It's business as usual rather than sort of new innovation now.
Councillor Boot.
Thank you, Chair. You talk in the report about Badgernet and about the NHS's goal for NHS trusts to 95% of NHS trusts to use an electronic patient record, replacing paper or handheld notes. While I absolutely agree that we need to have sort of more portable patient notes, my concern is that if there was power cuts, internet loss, ransomware attacks that we've seen previously, how can we assure that these patient records are still accessible by the medical professionals who need to have them?
So obviously that's a question for the digital team, but as with anything, you have multiple backups on servers, you have business continuity plans with any digital system. You know, the the vast majority of hospitals are on full EPRs. So obviously Badgernet is very specific for maternity and neonatal. We have our sort of nerve centre EPR for the rest of our adult population. But yeah, you're quite right. If you had a sort of a cyber attack, then you would need to revert to business continuity. We have a really robust cyber team that are very proactive in detecting any threats.
Unless you've got something, Chair, I'm happy.
Sorry?
I have got other questions, but I don't want to.
Councillor Peake, and then back to...
Thank you, Chair. My question is regarding the improvement. The report highlights the improvement in emergency department performance. What specific action contributed most to these improvements, and how will they sustain?
I'm not sure where it is in the report. If you can guide me to that particular... I can let Paul take this.
So obviously this is business as usual. Our whole drive is to improve performance in urgent emergency care. We were part of the Getting It Right First Time Further Faster programme, which looked at emergency departments. There were around 24 sort of hospitals in the country, led by the Getting It Right First Time team. I think consistently in both of our hospitals we have really good ambulance handovers. And so, you know, we were looking at sharing learning from other organisations as well, but others were taking our learning from how we manage our teams. So we have slightly different challenges on the Bedford site. Bedford, it is very much around getting patients from the ED into inpatient beds, and that's a sort of a flow issue. So if we get the discharges right, and as George has outlined, this home first pilot, if you're getting our patients out that don't need to be in hospital, you'll have improved flow from the emergency department onto the wards, and therefore that will improve your ED performance.
I think with the Home First, I think with the Home First pilot that's underway, you'll hear much more about that in the next quality account, because it's just about to take off, isn't it?
Well, that started on the 22nd of June, so it's obviously we're very new into that.
Councillor Bridge.
Thank you, Chair. You mentioned it's page 108 of our bundle, page 85 of your report, about staff recommendations. So that's the percentage of staff employed by or under contract to the Trust during the reporting period who would recommend the Trust as a provider of care to their family or friends. I can see that we are, from 25-26, below the national average at only just under 60% of people working for the Trust would recommend the Trust for care for their friends and relatives. I can see that you put some mitigation items in there. So, for example, successfully delivering senior leaders and clinical directors leadership programme, aligning the Trust CDI strategy, progressing the design of cultural competence training. None of that mentions anything to do with patient care. I get that these are all sort of top things that filter down, but I've heard a lot of, horror stories recently about patient care at the hospital. One child, for example, was told he had a heart condition, but then was told by Addenbrooke's he didn't, went back to Bedford Hospital. They said, oh, sorry, a technician made the diagnosis. He doesn't have a heart condition, so he'd spent 6 months thinking he had a heart condition, was going to die, has now got PTSD and refuses to go anywhere near a hospital. I've heard of people who have a swallowing difficulty, who've been on a ward, who was also type 1 diabetic. There was no food available for them to eat, and their swallowing difficulties weren't taken into account. So the comment was, I would rather be at home because I'm going to die if I stay on the ward. So there are issues with patient care that I'm hearing regularly from patients. This is obviously potentially reflected in the view of Trust members who wouldn't recommend that their families and friends are treated by the Trust. So other than these sort of high-level bits and pieces about leadership, EDIA strategy, is there any work going on to just generally improve patient care? And I noticed that Central Bedfordshire, in their comment on the report, mentioned that in this quality report there is no mention of the quality of care to patients. It's really quite high level. It's looking at statistics and how we compare nationally and to our neighbourhood trusts, but there's very little actually about quality of care for patients in this. So is there work continually ongoing? Can you reassure us that there is continual work ongoing to improve the care for patients in the hospital?
I can assure you there is. Obviously, no one wants to hear those stories where, you know, there's poor patient care, you know, or something hasn't gone well for a patient. We have various mechanisms for reporting those, speaking up mechanisms, incident reporting mechanisms, complaints avenues for, and PALS, which is a kind of precursor to complaints, to try and resolve things more quickly. I think with the staff survey and, you know, sort of elements about where people, you know, what people do, think about where we are. Within the report, there's something around the 13 acute trusts within the east of England. We place 4th as a recommended place to work. I think it's, it's not easy when we hear these stories, but if you look at the quality priorities, I think I would disagree respectfully that there's nothing about patient care or quality of care in here. If you look at the quality priorities last year and the quality priorities this year, there is a real commitment to make changes. If you look at the wealth of audits that are ongoing and described within the report, that is all about best practice standards and where we sit amongst best practice standards. So there is a real drive and commitment to care for patients. And as our colleague over here said, most of our staff live locally. They have family who come to these hospitals. They want it to work for them when they use the services and for their families. But definitely we have, you know, a real commitment to high quality care. And I think if you look at the variety of quality priorities, you will see that from last year and this year. And the ones from last year don't go away. We continue on with those as business as usual and through different you know, project groups, etc.
Thank you. Just, sorry, as a follow-up, Graham. I seem to remember reading, and I have slept since I've read this report, but that people were still feeling slightly apprehensive about using the Speaking Out service. So my concern is that if it's reliant on members of staff speaking out, then there may be an inherent, not bias, but that people may not feel free enough to mention when there are issues. I have got a resident who has gone through PALS, requested her deceased husband's medical records, got sent someone else's medical records included in that bundle, had to get back in touch with them to say, you sent me some wrong information. But yeah, I think there is, I appreciate that there is a lot of work ongoing, and I'm very pleased to see the fact that there's one of the priorities is improving communication, because having heard from someone today whose husband was pretty much close to death, had to fill in a respect form. His wife had no idea what that was ticked to say that the patient was compliant with it and understood what was going on. The patient couldn't actually speak by that point, didn't have his hearing aids in, was deaf. So I think improving the communication about the forms and what people are actually signing, I think is a definite positive way forward. But yeah, I'd like to, as I say, I'm sure most people here will have heard issues with the Hospital Victoria ward at the moment. Seems to be coming up high on my list of issues with the hospital. But as I say, I appreciate the steps you're taking to improve things going forwards for this year as well. Thank you, Chair.
Just, I know Paul wants to come in, but again, you know, those stories are very specific, and you know, I can't really comment on those, but we would always want to hear, you know, if there's something that hasn't gone well, we would want to support and ensure that they could access support to hear what's gone on, so that we can work to put that right and kind of work with them to understand what's happened. And of course, information governance breaches, you know, they would be reported, so where that's happened, they would be dealt through the appropriate processes. In terms of the Freedom to Speak Up Guardian, we have two, and they also have other channels champions who are out there sort of being visible and available. And I think even with the improvement, perinatal improvement programme in maternity, there are mechanisms there for speaking up. I think there is also with the instant reporting system, that is another way of speaking up, and we see that through there. So there are a lot of ways for people to speak up, but there will always, and Paul and I sit on various instant panels, and we are always very mindful of the just culture ethos and what NHS England now call being fair, and we talk a lot about those kind of issues. So I'll let Paul come in. Thank you.
I think you covered quite a lot what I was going to say. So I think with those anecdotal cases, I think go via PALS. I think they will absolutely address those. And yeah, absolutely, we share the importance of that. So.
Thank you. Are there any more questions? Councillor Clunes.
Thank you, Chair. First of all, I'd like to endorse Councillor Aboud's comments from experience with a relative, and also what I hear from residents too. Whilst we can never make generalisations based on individual cases, even when they're as extreme as the one that Councillor Aboud has just mentioned, I think when you see this happen repeatedly, it builds a picture. And it is one that, as elected representatives, I think we would have concern that it seems to be, you know, these cases of people of dissatisfaction, it seems to be more than is acceptable. I know that in anything in life, you never get 100% perfect. There will always be things that go wrong. That's the nature of life. But it just does seem to be that anecdotally, there is a lot going on there. My specific question was on the issue of waiting lists. I couldn't see anything in this report about waiting lists. Now, I may have missed it. It's a very long report, 117 pages. But I couldn't see anything in that. And for me, waiting lists is a key indicator of quality, how long you're on a waiting list, bearing in mind some people are in acute pain all the time, that they are on waiting lists, or they're in difficulty, or have mobility, whatever it might be. Being on a waiting list is an issue. I couldn't see anything in here. Have I missed it, and can you point me to it?
No, there isn't something specific on waiting lists. There are various metrics in there. The quality account has statutory requirements for this very long report of what is included, and that isn't a requirement. You'll probably see that in board reports, I would imagine, and other sort of trust papers, but it's not something for this quality account. However, when you see things like site redevelopments, etc., those are all things that enable throughput of patients, so that the flow is better, we're making sure that they're discharged in a way that sort of ensures their safety and safe care.
Absolutely. So the operational performance, so waiting, etc., covered in the public board reports, and so each time the board will see that, and that's accessible. I think we are absolutely making progress in some of those very long waits. So, and obviously we need to reach our constitutional standards of getting back to 18 weeks wait. That is quite challenging. It's quite challenging across the country. In fact, there was a meeting, a regional meeting today, that actually Bedfordshire Hospital as a trust were making very good progress compared to the rest of the region. But there are issues like industrial action, previous resident doctor industrial action, that will affect the ability to maintain those waiting lists. So it's 2 steps forward, sometimes 1 step back. But absolutely, we're committed to improving that.
Thank you. Councillor O'Teal.
Okay, just regarding my question about improvement emergency, is page 9, second paragraph, second and third paragraph. Just is a briefly mentioned that is an improvement in emergency service,
Sorry, this is in Kathy's. In our CEO introduction, is that what you're talking about it there? So I think she's described some of those things, the sort of improving the standards, etc., working with our partners in the ambulance service, etc., and setting up contingency wards as we need to, where we have, a high intake. don't have anything else to add on this.
No, that's fine. I'm happy with the answer. Just you said it's not part of the report, so I thought it was in the report.
I beg your pardon, because it was in the foreword and it wasn't in the other bit, but I accept that. Thank you. Sorry.
Thank you. Councillor Abood.
You mention, and it's page 76 of your report about the Bedford Elective Hub. We've heard about this before, previously in this committee, which is a very exciting prospect for the hospital. But I noticed you say that no final decisions have been made to proceed with construction, which would be subject to DHSC consideration and approval. Do we know sort of any kind of timelines when any decisions might be made so that we can start progressing with this project?
So I think the report covers that. I think we're expecting that approval in autumn of this year, and in which case then obviously construction will take place with the expectation will open 2 years later. Obviously it is really important. It's important for the whole trust. So it will be a Bedfordshire Hospitals sort of elective hub, and we expect there'll be lots of sort of low complexity, high volume cases, particularly orthopaedics, and that would be, I think it would be great for our population of Bedford Borough and other populations.
Do we think there's going to be are there any concerns that it may not get signed off?
There's always potential concerns, but certainly the national team are sort of supportive of us, and I think our BLMK patch is one of the only areas, Georgia will agree, that we don't have an elective hub, so it is recognised there is a gap here.
Thank you. Any further questions? Are there any comments on the report? Just a comment from me. I was looking at the 2.1 achievements in quality improvement, and I note the areas that remain in progress and appreciate the continued focus on embedding learning, improving patient experience, and strengthening continuity of care. I'll just say thank you for keeping us all informed, and I look forward to receiving future updates on the delivery and outcomes of these initiatives.
Thank you, Chair.
Yeah.
Okay, the report could provide clear comparison with the previous year and national average for key performance indicators, so KPIs. That's my small comment, that's it. That you could provide, like, the previous year and this year, KPI is more clear, yeah? That's right, thank you.
That's noted. Some of the tables do have, the previous years, but we can certainly note that and consider that for the forthcoming quality account. Thank you.
Thank you. So are members therefore happy to note and submit the committee's draft report regarding the agenda item to Bedfordshire Hospitals NHS Foundation Trust for consideration? All those in favour? Thank you. On behalf of the committee, may I thank the Deputy Director of Quality and Safety Governance and Medical Director for their report and attendance. Thank you. Okay, move on to agenda item number 7, scrutiny review, palliative care scoping template. The committee is invited to consider the draft scoping template for its scrutiny review regarding palliative care. Are there any questions on the template? I'll just give you a few minutes. Yeah, you go.
I just think it would be helpful just really to pick apart, as part of this review, I mean, it comes under some of the bits and pieces that we're looking at services working together to form an integrated service, transition points as people move between services, but it would be helpful to look at that from a patient's perspective and which organisation the patient comes under. Because I've had a resident who's tried to contact ELF about records for their husband. Elfter said it's nothing to do with them, despite the fact they were under the palliative care team, said that they needed to go back to the hospital. So she's being bounced backwards and forwards, unable to get the records that she wants regarding her husband's care. So it would be good to try and sort of just pick apart where, if everything is working in tandem, who the patient comes under, so that if someone does need information following someone's passing, where they can go to get that, just to be a little bit clearer in our own minds about how that works.
Are there any more comments on the template at all? No? Okay. Thank you. So are members therefore happy to agree the template with the amendments, committee scope and next steps for its review? All in favour, please show. Thank you. Thank you. Move on to agenda item number 8. To consider any call-ins, the committee is invited to note there have been no call-ins at this time. All those in favour, please show. Okay, we'll... It's on here, of course. So, we'll therefore move on to agenda item 9. Record of decisions of the executive. The committee is invited to note that no decisions were taken by the executive at its meeting held on the 3rd of June 2026, which fall within the remit. Sorry, I'm reading really fast because John needs to go and watch the football. I do apologise. Fall within the remit of the committee.
This is an important committee, he can wait.
Okay, so which fall within the remit of this committee. All those in favour, please show. Okay, thank you. And summary of relevant individual executive decisions. The committee is invited to note that no individual executive decisions falling within its remit have been made since its last meeting. Agenda item number 11, notice of forthcoming decisions to be taken by the executive. The committee is invited to consider a summary of items included in the notice of forthcoming decisions to be taken by the executive for the 4-month period from July to October 2026 that fall within the remit of the committee. There is one decision relating to Wixham's GP surgery delivery option decision. Does the committee wish to add this item to the work programme? All those in favour, please show.
Will it delay it, Chair?
No, oh no. Oh, sorry.
No, your mic is still on, sorry.
Oh, sorry.
Can we just clarify, the decision is on the agenda. Do you want to do that as post-decision scrutiny? Is that what you're saying? In which case it wouldn't delay anything. We wouldn't be able to do it as pre-decision because we wouldn't have the time. So you want it programmed in as post-decision scrutiny, or because you haven't seen the decision yet, so you don't have to accept it. It's a choice that you have on whether or not to include in the work programme.
Chair, as a member for a ward affected, obviously I've had lots of discussions with officers about Wixham's GP surgery, and I think I know most of what is going on. So I personally, as a ward member, have no wish to necessarily to scrutinise it, but that doesn't prevent other members of the committee having a look at it if they think it is if it is worthwhile. Sorry.
I think from discussions that I've had previously, all the new GP surgeries are sort of looking to be built in a sort of fairly standard model, so that they're easily adaptable, the treatment rooms are easily adaptable. So from an actual build perspective, I don't think we would have any concerns about the structure and how it's going to be actually built. So I'm quite happy to go for post-decision scrutiny and just have a look at it in our next meeting to see what actually was decided. But I think obviously the GP surgery in Wixham's is a priority, and yeah, wouldn't dream of wanting to hold it up. It needs to happen.
Okay, it's getting hot in here. So we'll move on to agenda item number 12, Committee Work Programme 2026-27. The committee has before it its work programme for 2026-27. The committee is asked to consider its work programme and agree the agenda items for its next meeting on 7th of September 2026 as follows. So we have palliative care, scrutiny review to receive a briefing from East London NHS Foundation Trust on palliative care services in the community and, sorry, musculoskeletal services to meet the new service provider and receive a report on services in the borough moving forward. Are there any suggestions for future to put on the work programme? Anything else? Any items you wish to add to the work programme?
Chair, can I just, while we discussed this matter earlier, just give you a moment. Jacqueline, I wondered, bearing in mind my point earlier about waiting lists, and I know this committee always has a very, very big agenda, a very heavy agenda, but I think waiting lists are important. Do you think it is something that we could programme in to the committee's work plan where we can review waiting lists at the hospital and look at progress made? I think it's an important thing. I accept the point we've heard this evening. It's not included in the audit plan, but I think you know it's a key part of care, and it's something that you hear about again when we talk about these anecdotal things and our constituents speaking to us. You know, people being on lengthy waiting lists. And the government's made it an issue that it wants to reduce them. I mean, all governments say they want to reduce the waiting lists. It's not always successful, and I'm not making a party political comment when I do that. It's all governments. But I just wondered, is it something we could put into the agenda going forward, please? Sorry.
Yes, I think, as the point was made, there are board papers available from the hospital. So perhaps the starting point would be to look at some of those, and then we can liaise with the hospital about when would be a productive time for them to come and report to you on progress with the waiting lists. So thinking about our work programme going forward, September you've got 2, potentially 3 items already, if you choose to go ahead with the item on Wixham's. November's agenda, we have 2 items on public health. And as we know, we like to make sure that we're giving each item due weight. So any more than 2 can become a little problematic. And then we'd be looking at December. But we would probably be able to get you something, if nothing else, the board reports we can have a look at and circulate them for the committee to consider and then think about how you want to proceed.
Absolutely. Sorry, Chair, if I might just come back. Yes, because I think, say, waiting lists, it's a how long is a piece of string issue. Reviewing the papers, as you suggest, Jacqueline, we could then sort of perhaps shape a narrative about how we'd like to discuss it and what areas we want to pinpoint. So, yeah, I would favour going along with what Jacqueline has just suggested, Chair. Thank you.
Can I just add a small comment to Councillor Coombs' comment there? I've been told in the past that 25% of primary care appointments are due to ongoing issues because they're waiting for treatment in secondary care. So it does sort of dovetail into our last year's work programme looking at primary care access. If we can look at the waiting list, because as I say, 25% of doctors' appointments are people who are still in pain, looking for more painkillers while they're looking for treatment at the hospital. So I think it's an important thing to be looking at.
Oh, I nearly had a full house if I can remember to press it. I'm not sure I should be volunteering, but actually, if we go back to the Our Way strategy, one of those key measures was around waiting lists. Maybe, and obviously the board reports are done, maybe we could do something combined in terms of, we talked about the baseline for Bedford Borough in terms of what, so we could maybe make that come a little bit more alive for Bedford Borough residents and then how it ties in with what the trust is doing. If that would be helpful.
Thank you. Okay, that concludes agenda item 12, and thank you all for your attendance and contributions. And there being no items of business, I declare this meeting closed.